Welcome to Killer Psychologist. Let's talk about nurses who kill. Forget about serial killers in ski masks. Today we're talking about the ones with name badges and nursing degrees. They're not lurking in dark alleys. They're walking hospital corridors. They're the ones that slip through the system and right into the ICU room, standing next to your bed, administering your medications. They hold a terrifying amount of power, and we trust them. And I assume, like most of us, that the nurse at my bedside wants to help me. So what is the psychology behind nurses who kill? That's what we're going to talk about today. How does someone trained to save lives end up taking them? Do they see themselves as the hand of God making decisions about life and death? Are they self-proclaimed angels of mercy, or are they just cold-blooded opportunists hiding behind scrubs and institutional trust? So we're going to break down some of the most disturbing cases, starting with Lucy Letby, the neonatal nurse in the UK convicted of murdering 7 infants and attempting to kill 6 more. Her methods appear to be quiet and calculated and deeply unsettling, injecting air into their veins or overdosing them on insulin. So what red flags did the hospital ignore? And who should be held responsible? How is the legal system supposed to respond? Are there even psychological checkpoints before someone's cleared to return back to patient care? To help unpack all this, I'm joined by 2 top experts, Dr. Craig Wetter, my colleague, forensic psychologist and attorney, and legal nurse consultant Shannon Casey. Shannon's the one the law firms call when a patient dies unexpectedly, and she reads the medical records like they're a crime scene. So Dr. Wetter and I are retained for other purposes in cases like this, like psychological autopsies, and we may be looking at other things like the mindset, motive, or the mental state. So let's be clear, most nurses aren't killers. My own sister is a nurse, and she just became a licensed nurse practitioner, and she has her kill count remains to be 0. So, Shannon, you're a nurse. So before we get into the killer nurses, what drew you to nursing? And in your experience, what kind of people are drawn to this type of work?
Thank you for having me on. What drew me to nursing was I had a family full of nurses. My grandmother and my stepmother were nurses. And I've always liked working and thinking about medicine and the human body and how it works. And after serving in the military, I was a combat medic for 6 years. I decided to use my GI Bill and go to nursing school. And I've been a nurse for about 16 years. Once I got into nursing, I really developed a love for people and for helping them. Not just in saving them, but also when you have a demise, someone's on palliative care or hospice, helping them and their families have the best experiences that they could possibly have. Because when you take care of people in a hospital, not everything's going to be roses and sunshine. You're going to have some death, I really like just meeting people, getting to know them, and helping figuring out I worked ER for about 6 years, and I really loved helping people figure out why they're in so much pain, because pain is it makes you afraid. Like, I'm dying. Like, pain means something's really wrong. And if we can figure that out, that was just that's what I really loved. And we could alleviate that pain, and we could put their fears to rest. Or, sometimes they did receive some pretty bad diagnosis, but we were able to start them on that journey of getting better, getting the resources that they need. The ER that I worked for was one that would put them in touch with the social workers, put them in touch with their next doctor's visit. So I really loved taking care of people at bedside.
And so when you look at the case of Lucy Letby, what are your first thoughts or impression?
Wow, my first thought was, what did the hospital know? And I found it. They knew probably several years before they formally charged her that something was up. And she had a manager that went to bat for her to keep her on staff. At one point, even though they had the Excel spreadsheet that she had more deaths on her shift than they had the entire year in a neonatal unit, there were pediatric medical consultants who were saying something's wrong. Please don't let her be on shift. The hospital still chose to bring her back. And they made those consultants issue a formal apology to her. When they had a few more infants that died while she was on shift is when they was like, oh, yeah, so something is wrong here. And it wasn't until after she was dismissed and several years had gone by, they started the formal criminal case, or even contacted authorities about it. We're not talking about the people who inspect hospitals. We're talking about local law enforcement. That to me was like a hospital that was trying to protect itself. Just like we discussed in the Shevnosky case about a month or so ago, the hospital was trying to protect itself. And so they were not pulling her off shift and putting her on paid administrative leave. They continued, even though they had the data in front of them to show that she had a higher rate of deaths than all year, they still continue to let her practice. That's actually a few of the names that you sent me to look up. That actually happened on several occasions where hospitals knew something bad was going on, and they still continue to let that person work at bedside.
Yeah, they don't want that civil liability. And I've firsthand seen this, and I have gone to the hospital to consult on a case, and there's something terribly awry by what licensed medical staff or doctors are doing. It's totally criminal conduct. It's total violations of patients' rights and a number of things. And I reported it, right? And nothing happens. So it's shocking, but it seems to be a theme of these institutions, these hospitals, covering for them, because that is in fact what's happening. And I'm sure Craig has something to say about that.
Well, there's, you got to think about this from the perspective of an administrator in a hospital, right? They're all about risk management, and obviously they don't want nurses that are killing their patients working in their facilities. But, if there's suspicions that something's going on, an administrator obviously is going to undertake some form of investigation to get to the bottom of what's going on. I understand in this Ledby case, and this is in Great Britain, right, in the United Kingdom, this had been going on for a while. And she seemed to be the common factor of, present when these infants were dying. I have a question for Shannon, because when I was researching this case, I didn't get a lot of detail in terms of the method that was used, or what they suspected the method was. But we could talk about, getting into the psychology of sort of the underlying motivations of why a nurse would engage in these types of behaviors. There's a number of things we can talk about, fictitious disorders and Munchausen's syndrome and things like that, the hero complex as such. But yeah, I'm just curious about the modus and how she was suspected of doing this. What did she do?
So I found so I watched several different documentaries and read quite a few medical articles about this case, because it's pretty widely known. We do know that she did overdose infants on insulin, and they found that by testing them for their C-peptide levels, which is high in the case of when you're giving somebody insulin, artificial insulin.
Yeah, exogenous insulin. Yeah, exactly.
And then she was also giving regular milk to some of these preemies. She was bolusing them with milk, regular milk, which all of us know, and anybody who is familiar with premature infants. You have to be very careful with what you give them orally down their little NG tubes. I know that in 2 cases, they suspected she bolused them with air. Like she gave them a syringe full of air into their IVs. And that's just about the only 3 methods that I could find on her. I would not be surprised if there were more. They don't have a full kill count on her. They have convicted her on 7 murders, but with her being there for several different years, they still don't know how many. I mean, I would say every death that she was on shift is probably her responsibility. Say maybe 1 or 2, because they're preemies,
Yeah.
Pretty sick kiddos.
Sure. What's interesting is that the modus, in other words, the method that she used, seems to vary, which is interesting because with serial killers, as we know, oftentimes their modus tends to be consistent in the way that they kill people. There seems to be a variation here. I'm curious about.
I think the reason why it varies is not because is behind the motive. The motive or the psychological issues that was causing her to want to do these things would probably dictate how she was doing it. One of the things they found odd about her and was kind of helped them build a case against her is she was checking up on family members 2-3 years after, almost observing them in their grief. They also said that when she was an infant, she almost died herself. And so there might have been some kind of psychological damage from that. But I think her method had more to do with her ulterior motives, which was observing death, a fascination with death and grieving, almost like a show. She was enjoying watching the show, or she found the show fascinating, not actually doing it, but watching the death in the show of the grieving parents.
Like voyeuristic, like watching
yes.
it. I thought the interesting thing, she sent cards. And I was just talking to Craig earlier. I'm like, I never sent anyone's card. But she went out of her way to follow up and attend some of these events with families, connect with them on social media and Facebook, and send a grieving sympathy card. Like she really wanted to stay in touch with them. That's just a little above and beyond. So it's this relational.
Yeah, it is relational. So that's interesting because, again, what Shannon's saying is that is she getting satisfaction in some way out of the observing the grief process of seeing the parents suffer. And again, if that's the hypothesis, we're dealing with a psychopath, right? This is somebody with a psychopathic architecture. They have absolutely no conscience. They have no capacity for remorse or guilt, right? Anything like that. So that's a whole different animal, as opposed to these nurses who have the hero complex, right? They're inducing, say, a cardiac dysrhythmia or something, and they're causing a heart attack to then go and be the rescuer, right? And that's a different sort of thing. Obviously it's still, highly perverse, right? But it's not the same as what this sounds like. This sounds more like psychopathic, personality architecture.
And she had some obsessive journaling where she expressed her feelings about this. So she journaled this and writing in her notebook. And maybe we don't even have all the pieces of the notebook. Maybe, but she wrote, "I am evil. I did this." And interestingly enough, she's been convicted. So she's, I think she's facing life in prison without the possibility of release. But now her attorneys are looking to overturn her conviction, and they're appealing it. And there's lots of media out, even in just the last day, having a whole different narrative, which is very interesting because I know, Shannon, you did the deep dive as looking into this. It's pretty incriminating, the timeline and the spike of deaths. I mean, you could go through the timeline.
And what they're what they're saying, and some even medical experts have come out saying it's, how do we know she really did it? All the evidence she was convicted on was circumstantial.
Yeah. Nobody saw her administering, air in in the bolus or anything like that. Nobody saw, there was no witness to any of these acts, or at least from what I saw, right? What I saw in what I reviewed. That's interesting.
And that's the case with most of the list of nurses that you sent me. That's the case with most of them, how they were convicted with circumstantial evidence. But when you have, I saw the Excel spreadsheet that they used to show that the mortality rate on her shifts was higher, and everyone else had onesies or twosies. She was straight down the line. So to me, that's more than circumstantial, especially when you go from only having maybe 26 deaths in a certain period of time to almost 140 or 150. I don't think that was the number. I think that was the number on another case. But
yeah,
the deaths got exponentially higher when she was on shift.
So
and that to me is like, how can you argue that it's not her doing stuff?
Well, and that comes into, and again, I don't know if they had an expert come in and talk about probability estimations of on an average shift in this type of a neonatal intensive care unit, like in these NICU units, what's the average mortality, turnover on a monthly or yearly or even weekly basis, et cetera. And then, you can look at it probabilistically, and you could say, again, if these number of deaths are so disproportionate to what the running mean or running averages are, then it's circumstantial evidence, though. It's the way that the court, the way that the law would view that is still circumstantial, but it is strong evidence, because if we can rule chance out, right? Because chance is like, there's going to be random fluctuation in the number of, say, neonates that do not survive, right? So there's going to be some variation in that, right? But when it deviates so far outside of that, right, in terms of the numbers that we're seeing when she was working, that's pretty strong evidence. I mean, it again, unless there's some other actor that could be involved here, like some other employee that might have had access to these infants during these times.
Well, and I think there were actually several pediatricians that were working that unit way before they even they really started thinking about it. They suspected something was up with her. Like all of the infant deaths, there were a couple of infants that they spoke about. Yes, they were in the NICU, but they were doing well. They weren't the sickest on the unit. They were, they weren't, because there's some babies that are born at 34 weeks, and their track record to getting that 36 week in discharge is smooth sailing. And, but there was a couple that were like, this child was just doing really well. Their scans were good. Their labs were good. And all of a sudden, and then when there was a set of triplets and 2 of them died, but the ones that died were not having any medical issues other than being premature. And the third one made it, but I think even he started to have some trouble. And they're like, but there was no pre-existing issues with these triplets that would cause them to go downhill so quickly. I want to back up and say, I think 2 that died, one of them actually coded and they brought him back. And then later on he died. And I think that's right. I've read so much about this case. I'm just like trying to keep up with it all. I mean, that's just like, what the heck? Like what kind of perversion brings you to the point where you think it's okay to kill 6 infants?
Well, it takes me back to the issue of the psychological profile. Again, we haven't, we can't diagnose her. And by the way, she hasn't, from what I can see, at least what's available in the public space, there's no evidence that she's undergone any psychological testing. So we don't know, right, what her psychological profile looks like, right? And we don't know that. But Dana, you said something about a journal where she's admitting to being evil. Did she did she confess to any of these? Is that what you're saying? In a journal?
Yeah, well, let's talk about this admission of guilt in your private journal. I mean, who's keeping journals writing that you're a killer? I mean, And so it's interesting now that they're trying to overturn this conviction and say she's innocent, and they're trying to explain away this journal. I'll read the journal entry for you.
Yeah, please do.
I am evil. I did this. I don't deserve to live. I killed them on purpose because I'm not good enough. I'm a horrible, evil person. There are no words. I am an awful person. I pay every day for that. I haven't done anything wrong and they have no evidence. So why have I had to hide away like a criminal? I'll never have children or marry and know what it's like to have a family. I'm evil. I did this, but I'll never know why. So these are like excerpts from her journal.
Yeah. And they're authenticated, right? It's been confirmed that this is her writing and all of this. And yeah, okay.
Yeah. The defense claims she was a woman under extreme pressure, and they're not confessions. Okay. While the prosecution argued that they're exactly what they're private admissions of guilt. And I want to go back to what Shannon said about her having this near-death experience as a child or baby. So I'm not sure exactly. I heard that too, but I'm not sure where that information came from because I went to go find it again today and couldn't find it.
That was in several different informational pages about her, but they didn't go into detail as to exactly what had happened. I think she said she would frequently say, "I'm so thankful for the nurses that saved me."
So I want to talk about that. So she had a near-death experience. She was saved. And like, if we want to think, what if she didn't want to be saved? Like the hand of God. Now she's coming back and intervening with infants and preventing them from having this life. Like she's not saving them. She's letting them die. Maybe she, people that are chronically depressed or feeling suicidal, don't like, maybe, what are your thoughts about that? She's now in this position of power. And these babies don't need saving, by the way. They're already living. These are healthy babies. And she's going back, she's intervening, playing the hand of God and killing them. So does she feel like, is there some connection there, Craig? What do you think? Like,
it's hard to know because we need context about like, how did she almost die? Was it due to the actions of somebody, like in healthcare or something, or or was this just something that just happened that no one really is responsible for? Because I could see we can, and this is not an exact parallel. When you look at like someone like Ted Bundy is a prolific serial killer and psychopath, right? We know he's a psychopath because he was assessed and so forth and all of that. And he even self-admittedly, indicated this. Well, if you look at his, he had this early, really attachment deficit with, his mother who essentially rejected him, right, and left him. And so a lot of that later behavior, that need to kill and, that retribution against women and so on was a product of that early childhood abandonment of his primary caregiver, his mother, right? And that's well documented. So I think, you need to know, because yes, some of this stuff, that happens to us as children can certainly impact our psychological development. We know that, right? From a number of, theoretical like models talk about how certain personality disorders they have a genetic vulnerability, and then you have the environment that certainly shapes the development of, say, a personality disorder. So that would be important to know. Like, was someone responsible for this, for her, her near-death experience that she had as a child, and how much of that did she actually remember, and all of that's going to be important too, because it could have, shaped, who knows? It could have shaped some of this. How she views, the healthcare system generally, and right. So, yeah.
And she had never had. I listened to a documentary about her childhood and her family life. She had a very typical family, mom, dad, a few siblings, I think. And then she had a lot of childhood friends. Even her childhood friends in the neighborhood have said this cannot possibly be the Lucy that we know. There's no way she could do these things. And to this very day, they still stand behind her. Even her parents do. Which, I mean, like parents can be kind of wishy-washy about that sort of thing, but they seem like normal people who are being gobsmacked with the fact their daughter killed a whole bunch of infants. I'd have a hard time believing that about my own children.
Yeah, that would be a tough one, right? I mean, obviously, especially, again, she doesn't sound like there were adverse child experiences that could have shaped, the development of a severe sort of antisocial personality. But
she was very well liked. She was a typical 20-year-old when she went through school, and she's now in her 30s, but she would go out and have a good time with her friends, go salsa dancing. The people at work had a hard time believing that it was her because she was very beloved by her coworkers. She never had any relationships with men or women.
That's my next question so I'm wondering about that piece because, again, did she struggle in this area in terms of interpersonal relationships? And was there some kind of, could that, be one of the factors that drove this?
So very early on, she made it known she never wanted to get married. And she was not known to have boyfriends or any kind of intimate relations with other individuals. And there was no statements that I can remember from anybody stating that she had been sexually abused as a child or been raped or anything like that, any kind of sexual assaults. So yeah, that part kind of puzzles me. And not so much that I think it's maybe a part of a larger puzzle. You have this otherwise gregarious person going out and enjoying life, and they don't desire a relationship or an intimate personal relationship with anyone. And they've said that from the age of like 19 or 20.
Yes, there's an incongruence, right? If you were to have told me that she doesn't desire an intimate relationship, which is fine. There are people that don't,
Yeah, absolutely.
But they also don't have good social relationships, and those are what we call those folks schizoid. So they tend to like a solitary lifestyle. They don't want to be in a relationship. They don't want to get married. They don't even really want to keep close friends. They kind of just want to kind of be on their own, and they're actually okay with it. But this is different. So this tells me there's something going on with with that lack of wanting an intimate connection with another person, right? And on an intimate level in terms of an actual relationship. So that's curious. I'm curious about that.
Yeah, I am too. And that's why I brought that up, because it just didn't line up with her social life.
Correct. Yeah.
But then also you kind of wonder how much her parents hid from the larger community. If you work long enough, and you guys have worked long enough, that when you meet your client or you meet your patient, you're probably also meeting their family. And they rely on one another to keep the facade going, right? It's like, yeah, they look normal on the outside, but on the inside, it is not normal. And I experienced that in healthcare. This alternative thought process that you see your patient taking, they would prefer to drink apple cider vinegar instead of taking their insulin to bring their blood sugar down. And then the rest of the family walks in, and half of them are missing limbs from diabetes.
From diabetes, yeah.
But you see where the person laying in bed got the idea that they didn't have to treat their diabetes with insulin. They could drink apple cider vinegar. So, or, you have, I've seen that on several different occasions that affirmed that families will cover, I wouldn't say cover up, but it's so normal to them to be as they are. They don't, and they've done such a good job of moving in society like that into a pure normal. And then you get underneath the surface and you're just like, y'all ain't normal. Normal is sitting on a washing machine, right? We all have our issues. But
you're right. A lot of family secrets are hidden, right? And a lot of things, the outward projection to their friends, family, or their friends and coworkers and such might not reveal what's really going on inside that family, right? Behind those closed doors. And
right.
So yeah, it's an interesting one. So yeah, there was no psychological information available for her, because again, they may have done evaluations, but they certainly haven't come out.
The defense, if the defense had her evaluated, they're keeping that under wraps because they don't want people to know she's a psychopath.
So that's exactly right. And I'm retained by the defense all the time. And that I do the psych eval and I see what I see. And I'm telling you that psych eval does not see the light of day. And there are reasons for that. I just consulted on a criminal defense case and it was like, I'm telling you all the things about this person, but that's never going to make it out there. And the defense knows that. So she didn't testify at her trial. She is not speaking. And I think I understand she didn't even attend her own sentencing hearing. And so all that tells to me there are secrets, and I can imagine what some of those are, but they're not going to be revealed, and maybe not for many, many years. But I can guarantee you any good criminal defense attorney has had her evaluated by a forensic psychologist, and they are not playing that hand at that time because it doesn't serve their case. If there was something in there that helped her case, like anything, right? Any mitigating factor, like she was on the spectrum or she had suffered from depression or she was abused. But let's just say she was abused or certain things that are family secrets. We're not going to talk about that. We're shutting the lid on that.
Well, they have, and this is in the United Kingdom, and I believe it's still true in the UK that you have an NGRI defense as well. So if they were going to try to, there's no evidence that they played that. And that would suggest that there wasn't or is not any serious mental illness. In other words, not a personality disorder, but a serious mental illness present. But that's something that, again, as a forensic psychologist, we would, if say the defense hired us, we would evaluate that client. And if we identified the presence of, say, a severe antisocial personality architecture, that's not going to get disclosed, because we're not going to use that report. That's going to be considered an attorney work product thing. And they wouldn't necessarily offer that unless the court ordered it. If the court ordered the evaluation, that's totally different. But if the defense is doing that independently, which they can do, they're not going to show that hand, right? Unless it was favorable to them in terms of a mitigation, right? Okay, there's post-traumatic stress, there's trauma-induced, trauma here, et cetera. We're offering this as mitigation in some way.
Can we talk about the insanity defense on another nurse case?
Sure. Yeah.
Sure.
Which one?
Let's go over.
Jolly Jane.
Which one was that?
From hell. Nightmares from hell. She confessed to 31 murders by injecting them with morphine and atropine. So this was in Massachusetts. So this is in the 1880s. 1901.
Yeah, 1850.
So, listen to this. She got off sexually. She was getting sexual pleasure from watching patients die slowly as she held them in her arms as they faded away. And she said, just to feel close. So she was declared insane and committed to an asylum for her life. Her goal, she didn't keep a notebook, by the way, and wasn't documented to have any remorse. Her goal was to kill more people than anyone else ever had. 31, night nurse from hell. So I already have trust issues. And now if I'm ever hospitalized, every one of these nurse profiles is going to be playing in my head.
She's like Nurse Ratched. So keep in mind that was late 1800s. Now in Massachusetts, yes, the insanity offense has been around since then. The insanity defense, just so the audience knows, has been around for several hundred years. It actually, the McNaughton rule, which was the original sort of legal standard, is a common law doctrine that actually came from a case out of England. I hope I'm citing that correctly, but I believe that's where the case is sourced. But it's, the United States adopted this standard, back in the late 1800s is when this kind of came into being. But back then, we didn't have a DSM. We didn't understand or really know how to classify psychopathy and personality disorder. So everything got lumped into insanity. Like, just personality pathology was just considered insanity. So this woman, was a sadistic psychopath, clearly evidence of psychopathy here. She got sexual gratification from watching people die. We see this sexualized connection in a lot of sexual sadists who are serial killers. That's how they get their satisfaction. They get sexually gratified from inflicting the pain on somebody else, right? Or watching somebody die. We've got several serial killers that have done that. So this is not someone with, quote, mental illness. And the audience needs to also know there's a difference between serious mental illness and serious severe personality pathology. They're two different things. The personality pathology does not qualify somebody for a not guilty by reason of insanity defense. So if she was tried today under today's standards, that defense would likely not be successful.
No, and I think up until the end, she maintained that she was not mentally ill. She said, "No, I am in my right mind."
That's true. She's not mentally ill. You were talking about this this current case, the one we're talking about, the 1800s.
Yes. Mm-hmm.
Yes.
And what's also interesting is that's back around the time they started being able to test blood samples for levels of opiates. And that's one of the ways they found her to be the reason why people died. I thought that was fascinating because I thought that didn't start happening till like 30s or 40s.
That's what I would have thought
started
too.
happening around that time.
Wow. And so atropine was around back then, right? So we use atropine it works on it can increase heart rate, right? So it's used for bradycardia, which is a slow heart. So you'll sometimes give that. But if you give atropine to someone with a normal heart rate, you're going to potentially induce an MI in somebody. If I'm remembering from my pharmacology training, that's what atropine does.
Yeah. I've not seen it happen very often. Not that I've ever given atropine out of the proper context.
Yeah, but yeah.
Well, let's move forward to the 90s. From 1993 to 1995, Orville, known as the geriatric Grim Reaper. This should be a red flag if you were hiring him and he said, quote, "Old people are sick, grouchy, and have too many problems. They should be gassed. They should be gassed."
They still do not have a proper count on how many people he killed. He confessed. He was convicted on 6, but when they cross-checked time cards, he was present for 130 deaths out of 147 between the years of 1993 and 1995.
Vermilion County Hospital, Indiana. He had potassium chloride to induce cardiac arrest. So geriatric Grim Reaper, his specialty was taking the old people right across the border to the other side. He's serving life in prison without parole. That was in 2000. And he's deceased. He died in custody in 2017. I'm sure he was old and grouchy and had a lot of problems.
He was actually loved by all of his patients. And what he would do is if he thought you were too fussy as an old person, he'd take you out. He didn't want to have to put up with you.
Now, that sounds very narcissistic. Like
yeah, there's...
as soon as you don't love me, and he was called the angel of death. And so he may have been an angel to some, but for the others, they got the death. So it's a very love-hate situation. How about let's talk about another.
How about the ones where they got or a hero complex, where someone is coming in, they want to save, they're histrionic, right? Narcissistic. They want validation. They want to be seen as the heroes, right? I think we have one of those.
Oh, the savior with the syringe. That's a good one. Oh, so Janine Jones, the death shift nurse. This is a pediatric clinic, Texas Pediatric Clinic and Hospital. This is in the late 70s or 80s. So Janine was convicted of 2 murders, but suspected in killing 60 infants. And he just thrived on being a lifesaver. So he would cause the emergency and then, he knew
Yeah,
when
you
that
give a
emergency was
paralytic.
happening and he shows up.
Right.
Well, and it was
So-
interesting that the method by which he used was digoxin, which is okay, but he also used heparin. Heparin and succinylcholine, which is a paralytic.
Yeah.
I can see the dig and the succinylcholine, but heparin doesn't kill you quickly.
Heparin's a blood thinner, isn't it?
It is.
Yeah. So, but he would cause a cardiac arrest
Event.
and then
Mhm.
come in and be this, because he would know it's what he was doing, right? And then he would come in and he would be there to, revive or, stabilize that patient, right? And then he's then seen as the hero.
So the succinylcholine, that's the paralytic. So tell me, Shannon, what happens in a paralytic? What happens to their body if I'm injected with that?
Your muscles all the way down to your diaphragm stop working. You stop breathing and you're awake. It does not knock you out. Usually in the process of putting somebody under for intubation, putting the breathing tube down, or for a surgical procedure, you're first given a sedative like propofol, fentanyl, a few others that anesthesiologists could probably speak more to that. And then you're given a paralytic so you don't move. So succinylcholine is one of those deep muscle relaxers / paralytics, and you literally you stop breathing and you're awake.
Okay, this is what my nightmares are made of. Like
You're
the
trapped.
scenes-
You're trapped in
You're
your
trapped
body.
in
You
your own
can't-
body.
Yeah. You can't like call for help or anything like that. Yeah.
So he was sentenced to 99 years in 1984. And then there was some legal loophole where he was eligible for early release, but they filed new charges against him in 2017. And in 2020, he got resentenced for killing an 11-month-old. So he deliberately created chaos and then played the hero. And that's a theme we see in this, when we hear Munchausen syndrome by proxy. Sometimes we'll see, hear about that in a mother or caregiver to their child, but this is in the nursing, so that caregiver position. So, sometimes they'll poison or make your child sick, and then you help them. And I've seen that. I do see it more often in females with their children, and there's a lot of cases about that. But there's a couple other cases here that we could talk about that are
I want to talk about Charles Cullen. He confessed to killing 40 people, but he was convicted, I think, only on 17. How he got through the system is he moved through hospitals. He in 16 years, he was in 10 different hospitals. And 2 different hospitals suspected him of causing deaths. And instead of addressing it, they just fired him.
And he just went somewhere else. Yeah, he
was a traveling nurse.
He went that's how often he was getting hired, like permanently positioned hire. He had a history of harming animals. He also had a history of depression and schizophrenia. He used to talk to cats running down the street naked. His ex-wife, divorced him because she was scared of him. Like, there wasn't a whole lot of details about the divorce, but that he was injuring their dogs. Let's see, he was let go from one hospital for stealing non-scheduled drugs. And these are the drugs that he was suspected of using of killing people. So hospitals knew, and they fired him. They did not reveal it to local authorities, how they even found out that he was doing this. Oh, I do know, actually. A nurse that he used to work with, she put 2 and 2 together and then did a shift report on deaths. And it revealed that he had a higher number of deaths on his shifts than any other shift in the hospital. And so the investigation started based on circumstantial evidence, but then I think they actually exhumed a few bodies
lethal doses. No, because I want to ask you this, because this is an important. Do you think there's a culture, in the healthcare industry generally, and particularly in inpatient hospital settings, where again, administrators, instead of say calling authorities and initiating a formal investigation, they just do what you said. They either fire the employee or they reassign them. In other words, they just don't. They're not taking responsibility for what could potentially be criminal conduct. Because again, I worked back in my law enforcement days. I was assigned to a large healthcare campus, a very large hospital in the Sacramento area. I won't name it, but I saw how that hospital system operated, and I saw, and particularly in California, an association called the California Nurses Association, very powerful union that is highly very protective of their members and such. And what I noticed is that, it's very difficult to discipline and to terminate nurses, at least in California. And I don't know if that's true, across the country, but I just wonder about that. In law enforcement, there's that, the sort of this code of silence that goes on where officers don't report other officers are engaging in misconduct, that kind of stuff. And I just wonder how much that goes on in the healthcare system, amongst nurses and other healthcare professionals, keeping things.
Well, as you can see in these cases, the hospitals were more afraid of getting in trouble with the nurse they were trying to fire rather than protecting patients.
Yes. So in other words, worried about, are we going to get sued because of a wrongful termination? Are we going to suffer liability, or is the union going to come in and create problems for us? So, these administrators, they worry about more than they worry about patient care, patient safety. And I just wonder about that. Are we too protectionistic, in this context of the employees? And that's what's allowing, some of these serial killers to get away with what they're getting away with.
I actually have personal experience with a off-balanced reaction to mistakes versus, say, like narcotics abuse. So I'll tell my own personal story, and it's not anything nefarious. There was a nurse that complained about me about having a spent vial of Ativan in my pocket. So it was empty, but it had say 1 or 2 micro, and Ativan is notorious for being very thick, and you can't draw the full dose out of the vial. So you're always going to have a smidgen left over. Well, when I'd given the Ativan, it was a seizing patient, and there were dozens of people in the room. And so I could not get to the Sharps container box to put the Ativan in the Sharps container box. We'd already scanned it. We'd already given it. There was a million people who saw me draw it out of the vial. I'm not injecting it into my veins, right? So I put the vial in my pocket to deposit later. I'd gone to the restroom, and I had all these tissues in my pocket, and I threw away the tissues. Well, I accidentally threw away the vial of Ativan. Another nurse saw it in the trash can and turned me in for it. So I got 2 weeks of administrative leave while all of my blood tests and urine tests came back negative, of course, because they were that quick to, I didn't even finish the shift. We were in the middle of a very busy ER shift, and they had me go home and then come back the next day for all this drug testing. And I'm I've never had an off narcotics count. I've never had any reason. And then they had come up with these other circumstantial things that were and I was just but that was going on. My scan rates were off because I kept getting put in the back. They were looking at my scan rates of all medications, and we had a week where our computers were down, the scanners to scan medications, they were all broken. So they used that as evidence to bring me in for drug testing too. And I was just okay, whatever. So they were super quick to put me on paid administrative leave. They paid me that money back, right? For those 2 weeks after I came up negative. Obviously, I've never used a benzo a day in my life. But I've seen a nurse get into a knockdown screaming fight in the middle of an ER with another worker in the ER the same nurse misgendered a trans person deliberately and told them to their face in front of everybody, I'm not calling you by your chosen name. This is your gender. I mean, like screaming at people. And they thought about it for about a week and suspended him for like 2 weeks and then brought him back. And I was just like, nobody likes working with him. He's like one of those people that you see him on shift and you're just like,
stay away.
Oh my God. Why is he? Do they hate me for putting? And it was, knowledge gap was there. It was like talking to him was like talking to a brand new grad student, even though he'd been a nurse for a really, the imbalance, the reactions, I've seen it be so way off. Like me being sent on administrative leave the night someone suspects me of drug use. But you've got somebody who is creating a personal, like, human resources nightmare with pissing people off and being rude and hostile work environment. And it takes an act of Congress to get him even put on administrative leave. And they still bring him back. And you're just like,
that's what I'm talking about. It's like seems like they're missing in a lot. Well, obviously, because we can see from these cases, they're actually missing. You're not seeing the forest for the trees, or they're missing like the bigger things. They're focusing and dwelling on the less consequential things, and then they're missing some of the bigger warning signs.
Well, in the case of the Shabnowski case, I learned later on. So remember, we talked about how from the time he died until the time he went to the medical examiner's office, it was the medical examiner that called the family and told them the liver was missing. It was not the hospital. It was a medical examiner that called and put in the word for an investigation to be done. It was not risk management of the hospital.
Yeah, the hospital was trying to keep it under wraps. Wow.
But that's how they operate. If there is a mistake made, unless it's so like egregious, even when it's egregious, hospital's not going to tell you. Hospital is not. They don't have to.
Yeah, that's their risk management strategy. Yeah.
So, and I've seen this actually a couple of times in medical charts I reviewed. Guy walks out, he can't use his arm. I found so many mistakes in that chart, but the family had no idea. The hospital never told them what actually happened. And it was me investigating, doing my own forensic analysis and criminal investigation of that chart to find the millions, like million and a half is what he got. And then the case of these cases where these nurses were immediately, anytime a person in a hospital is suspected of doing anything, what is the harm of putting them on paid leave for a couple of weeks while you check into it? I think it would create more trust in the hospital system, right? I mean, that's just to me is like, but because of that, we've got notes of nurse after nurse after nurse of physicians who cause serious issues. And the hospital is like, well, we just won't tell people.
Charles Cullen worked in 9 hospitals from New Jersey to Pennsylvania. He was the death commuter. He was a traveling nurse. So
how did that not make it way on his nursing license? These are state-run boards that give nurses permission to work in those states. None of those complaints made it on his license.
So he actually got letters of recommendation. So despite suspicion, spikes in deaths, and then he was allowed to resign and then quietly move on with, checking the box, being recommended. And so he's serving 11 consecutive life sentences. He was sentenced in 2006. So it looks like this inspired some systematic reform in the hospital reporting and nurse background checks.
Background checks.
And I have somebody I went to school with. I won't name them. They became a nurse, but they're an absolute alcoholic. The number of DUIs is 3 or 4. a few assaults, in out of jail, has a drinking problem. Driving to work for a traveling nurse, by the way, got in a wreck on the way to a morning shift, ran away. Like, I don't know how he kept continuing to work. And
he's in California, right? He's in California. That's your answer.
California, and
he's in California. Good luck getting someone's license suspended in California. Seriously, for any professional license, it's very difficult.
Drunk on his way to work every day, and I'd always talk to his ex-wife, and I go, "How does he still have a nursing license?" And year after year, and I go, "Because he was just he wasn't even fit to parent. He that was all gone, everything dissolved. So he's just so traveling nurse. Watch out, traveling nurses." So he just went to different places, and so you could do a short stint and be like,
you can keep it together for those 6 weeks you're at those places.
Oh, yeah.
Because that's usually how long...
locums contracts, the short-term ones.
And all they do is if you have issues at the hospital, they just ask you to not come in for your next shift. There's no formal firing process. They just call your agency and said, don't send that nurse back to us.
So let's talk about the Canadian killer.
Which one was that?
Elizabeth Wettlaufer, convicted of 8 murders, plus 4 attempted murders, and 2 aggravated assaults. This is from 2007 to 2016 in Ontario, Canada. She was working in long-term care homes and private residences. And her method was insulin overdoses to elderly patients. And she says her hands were guided by God. And she said she was only relieving their suffering. And she confessed to a pastor. So she was very religiously preoccupied, and her diagnosis. So she had some substance use problem, not shocking. I don't know what it was, but she was in rehab, in and out, and she was diagnosed with borderline personality disorder. And she was psychiatrically hospitalized. So she was arrested in 2016 and she pleaded guilty. She's serving a life sentence in prison, 25 years with no possibility of parole. So this triggered some inquiry into the oversight of nurses in Ontario. Like, how did we get here? Right? So it took these cases where many people are dying, what systems are in place. And we look at private residences, right? What are the checks and balances? Not really much. I mean,
they do a background check, right? In terms of a criminal history check, and they do drug screenings and all of that stuff. And they might check a couple of your references. But one of the things that they don't do, this is for any healthcare professional, is they don't do a psychological evaluation. And that's something that, we've talked about this for other professions as well. For example, for psychologists, should there be some psychological screening? And there's lots of sort of arguments for and against this, but I'm curious about what you think about that, about whether should there be some type of psychological, the screening process just to ensure that someone is not experiencing a serious substance use problem or other, major psychiatric or psychological or emotional internalizing problem would cause, difficulty for them in their work.
I think just like we do pilots, pilots that are flying a $1 million piece of equipment, you need to have a psychological screening because not only will you kill yourself, you'll waste those millions of dollars and you could potentially kill others. If they demand it for them, why not? And we as nurses are handling potentially lethal medications if not used properly, or if you've got a psychiatric problem, you're going to use them improperly.
Exactly.
Right?
Yeah. And the nurses, the doctors, yes, they have access to the medicines, but who's administering the medicines, right? Generally.
It's nurses and anesthesiologists and some other cases, you've got other specialties that are using them. But I personally wouldn't oppose for my own psychological screening just to prove that I am a safe person to practice.
We've already evaluated you, Shannon.
You just didn't know it.
But keep talking and I'm diagnosing,
Well,
right?
I give you the results. Actually, everybody listening has already diagnosed all three of us. They've formed their own opinions about us.
Of course.
I have suspicions about myself, but I'm in therapy. It's good. We're good. Nobody's called.
Fine.
I'm not been Baker acted. I think a yearly psychological examination of any healthcare worker that has access to the means to seriously harm someone, whether it be with a scalpel or medications, should receive psychiatric screening. And not just because there might be an undiagnosed issue, but look at all of us who went through COVID. How much that was traumatic. It was very traumatic for a lot of us to experience. There are a lot of nurses who have stepped away from bedside because of the level of mental strain that we experienced.
Oh, and a lot of physicians have left too.
We've had some nurses and physicians commit suicide over it. I know that working in the ER, I've gone from a room where I just coded a patient and they passed away and I had to go next door and take care of a sore throat. There is no downtime between death and taking care of otherwise healthy patients.
That's a lot. And Craig, let's talk about the shitstorm you had the other day at the psych facility.
So just another day inside, an acute care psychiatric facility. Well, so yeah, you're talking about the patient that isn't mentally ill necessarily, but has probably some severe personality pathology. Is that what you're referring to? Or the staff?
I'm talking about the one that had a handful of shit.
Yes, all of the inappropriate behaviors that, again, sometimes it's psychiatric, sometimes someone's decompensated to the point where, they're not in touch with reality and they do play with their bodily fluids and throw things and that kind of stuff. And that happens more in correctional and forensic settings where we see this happen frequently. So, that's a setting where, healthcare workers are getting exposed to, there's nurses and there's other, support staff in these facilities, like where I work, who are being assaulted. Okay. And I just got into a interaction that resulted in an assault as well this last week, in this facility. So that causes a lot of stress, particularly for, the nursing staff that are working in these facilities. That's certainly, doesn't happen in all settings, right? That you're probably not going to encounter, or healthcare workers may not encounter that to that degree, like working in a hospital, in a regular community hospital. But yeah, when you start working correctional and you work forensic, you're going to see all kinds of, behaviors like that are directed at staff that are sometimes volitional, meaning it's due to a personality disorder, not necessarily a mental illness. And that burns people out. There's so much turnover, in the facility where they're constantly bringing in new people because, the staff, they don't stay because they burn out and they just get stressed out. Same thing in the correctional setting, in the prison systems, like even I don't know about in Florida and other states, but I know in California, there are constantly, nursing, physician and psychologist positions constantly open in these places because they can't keep people, even though the pay, it's some of the top pay you can get, right? They offer incentives to get people in, and then, they get in there and you go, oh, this isn't what I thought it was going to be. It's like, I got people they're throwing bodily fluids at you. They're trying to assault you, this kind of stuff. So
my rule of is, I don't want to be involved in those high risk, high liability situations. And, my sister's a traveling nurse. And so I know. She just graduated with her nurse practitioner license, and she's going to start her her 2-year residency here in a couple weeks. So in between the 2 weeks, she's taken some shifts, traveling nurse. And interestingly, she comes in and they just, after a day of training, they're like, can you work night shift all by yourself? Like all alone in a big building with, it's so, the risk is so high. And of course she declined. So it's not, you can decline those situations, and I decline them when you're saying this exceeds what I could do. There's not enough staff. I'm not going to. They need your license. They need to check the box that they have this license, whether you're a psychologist, nurse, whatever, to run this thin skeleton crew. But you're like, no, it's all on my license. If anything happens, if anyone dies, I can't get to them. Like, it's on me. It's on me. It's on my license. So when you see that, you just say no. And a lot of nurses, like, you're pressed for money and you just take the shift and you're like, and then something tragic happens. Well, you definitely can say no. And that's why I don't take some of those jobs, because I evaluate the risk and I'm like, it's not worth my license.
Well, it's also not worth you getting sued by, and again, in these frivolous lawsuits that get filed, again, and depending on the setting, if you're working forensically, right? I'm talking forensic settings. We get, I got sued when I worked and doctors get sued all the time. And majority of the time, these are frivolous lawsuits. The inmates file these because they get to file them for free. They get access to, legal help to do that. They tie these cases up for years. The state then has to hire, they have to have the attorney general then represent you. The state and the employee now has to be represented, and you get drugged through a lawsuit, and that can involve interrogatories, depositions. And, in my case, the suit got dismissed with prejudice, meaning that it had no merit, warranting, further progression. But it took 3 years for that to happen. That's a lot of stress. And and knowing that this was completely frivolous, it doesn't matter because anybody could sue anybody, basically. So there's all these different, things that I think healthcare professionals have to think about when the setting they work in can create a lot of stress for them, and that can cause people to go over the edge, unfortunately, and start to do things, cut corners, or do things that get them in trouble.
I've seen a few that develop drug and alcohol addictions.
Yeah, absolutely. Yeah.
It's their only way of coping.
Yeah.
Alcohol is a legal drug, right?
Uh-huh.
And if you have problems going to sleep after a shift, let me knock back 1 or 2. And it turns into 6, 12.
Yep. I worked at a place and that nurse was totally under the influence, as evidenced by she was a fall risk. Like, put a sticker on her, fall risk. Like, you're not safe. You sit down and, like, it's obvious. Guys, get her out of here. Like, for all the liability reasons we can think of. She's not safe for herself. She's not safe to drive home. Like, someone call her a taxi. She's slurring words. I'm like, is anyone else not seeing this? So let's talk about, we have one more nurse. We got to give her attention because she certainly needed to gain attention and praise from staff and grieving patients, right? Beverly Allitt. So she worked in Grantham and Kesteven Hospital in England. She murdered 4 patients and seriously harmed 9. This was in 1991. And another angel of death.
I wonder why a lot of these cases are happening in England. That's interesting. I don't know. It's like, are you noticing that?
I have a theory about England.
Oh, do tell.
So I've always gotten into medical documentaries since I was a kid, and the most interesting birth defects come out of England that I have ever, they don't happen very commonly in other parts of the world. And I will say I love people from England. I'm not bashing them at all, but if you think about it, Queen Victoria was the mother of the Empress of Russia that was murdered. She was also married to her cousin. They did a lot of consanguinity in English royalty, French, and Spanish, Spanish royalty.
A lot of DNA diversity is what I'm hearing here. There's not enough. A little too close. The family trees, they're a little too close together.
And with England being such a small island,
yes.
there and the 23andMe, all the DNA testing that's coming out, there's stories of people getting their 23andMe's back and finding out that their father was really their uncle, or they're really married to a cousin.
This goes back to the days of
funny because I was just going to do 23andMe, and my family's all into it. Everyone's done it. There's like hundreds of profiles in there. I feel pretty safe at this point, but
don't go out and don't become a serial killer, because they'll track you with the.
Well, and it's also an incredibly small island with a very high population count. And so, per square mile, you're probably going to have more psychopaths. Yeah. I just find it very, understanding genealogy, understanding how intermarriage was normal up until like 1950. Queen Elizabeth was married to her own cousin. He was a cousin through, a first cousin. So that was not unusual. And the hemophilia that in Russia, that came from Queen Victoria. That's my theory. They also like to sensationalize things over there. Their tabloids are like, we have the National Enquirer. They have like 12 publications over there that will, you burp the wrong way, they're going to write about it. They got nothing else better to do over there.
Lots of histrionic sort of personality stuff going on over there like this. Yeah.
Well, I wonder if this Beverly Allitt made the front page. So she is being held in a secure psychiatric facility. So she's the one that killed 4 people, injured or harmed 9. And so psychologically, let's talk about her. So she wanted attention and praise from staff and from grieving parents. And she wore a special teddy bear pin on her uniform while injecting toddlers with lethal doses of insulin and sometimes potassium injections, and sometimes, Shannon, suffocation. Wearing her teddy bear pin. Okay, so people thought she had fictitious disorder. And Craig, you want to talk about that?
Well, fictitious disorder is the newest way we classify what used to be called Munchausen's syndrome, and then Munchausen's by proxy. So it's now fictitious disorder. And so generally what that just means is, and again, you're correct that women tend to be more likely to get this diagnosis than men, although it can be both. But in this case, or in the case of fictitious disorder, the primary aim is attention seeking through inducing some sickness in somebody that you're closely connected to, and usually that would be a child, but it could be also an adult as well. But it's generally somebody that's under your care. So you're usually a caregiver or in some caregiving role, and your need for that reinforcement validation is achieved through making the child sick and then taking the child to get care in most cases. And then that's how that generally will develop. Now, in her case, she caused the death of at least 4, correct? So from what I see when I looked at this case, is that was the diagnosis she got. She got a fictitious disorder diagnosis. That was my understanding, but I'm wondering about if that was all she should have gotten.
Well, I wonder if with those medications that she gave, she was intending for them to survive. So she intervened, hoping that they would survive. And it was really not something she intended on doing. But that's just what stands out to me. The suffocation, You can bring people back from anoxia.
I guess you could. Yeah, that's true.
But then if the patient dies under your care, you're still getting a lot of, you poor thing, blah, blah, give me a
you're getting
hug.
the sympathy and all that kind of. So that's the reinforcement, the validation that the caregiver, that's what they're getting out of it. So obviously if it may not be that the intention is that child or that the person under their care actually pass away. And so that goes to the issue of intent, right? Too. It's like, so if the prosecution is prosecuting a case like this, in order to prosecute someone for murder, you have to prove intent to kill. Intent to kill is specific intent. So again, this could be something that, defense could use. So you see where I'm going with that as mitigation. If it's fictitious disorder, then they could try to get the intent to kill removed, and then it becomes a voluntary manslaughter, right? That would be the crime that she could be found guilty of if in fact there was no intent to kill. Does that make sense? So but again,
I have seen though, I have read though of people with fictitious or Munchausen where the child died and the sibling starts getting sick. So maybe that's like their intention was to cause, you get what I'm saying? Like their intention was to cause the slow death or the quick death, and then they just move on to the next patient. And
yeah, it doesn't mean that there isn't some intent there possibly because again, they're getting their internal needs met by engaging in this caregiver role where they're seen as, hey, I'm, poor me, look at what I'm dealing with, right? I've got, this sick child all the time, and and they're looking for validation. They're looking for support. Those are the psychological needs that they're trying to satisfy. And by putting in, and of course, they're poisoning their child or doing whatever they're doing to garner that.
And anybody else notice how many of these cases are with children? Like, you would think that attacking children would be like the unspeakable thing to do. Why? Because old people, they get on your nerves sometimes. I'm not condoning what he did, obviously. Yeah. But children are innocent, and it just doesn't, it makes no sense to me. Like, why would you attack or kill a child other than the fictitious disorder?
Yeah. What is the name of the movie that had Bruce Willis in it? And it was about
The Sixth Sense.
Yeah. Poit was putting pine sol in the soup.
Yeah.
Yeah.
And so I always think of that, and just think of the facade that she presented at the funeral, and this really narcissistic facade of just how people perceived her and grieving and the attention she got. Really think about it. What kind of person, they need that attention, and they're willing to do anything to get that. Really think about what it takes for those ingredients for that type of person to go so far where you're spiking your kid's soup and they're sick in bed and you're playing this victim. And I worked in the psych hospital for many years, and I've had many sick patients, and their caregiver was sus, and their labs were showing up crazy. And I would never put too much faith in your caregiver alone. There should be checks and balances, but honestly, I have trust issues, and thank you for all
Well, yeah, that's because again, it's not just fictitious. There's other personality architecture involved. There's histrionic, narcissistic. So it's the cluster B stuff, right? We see again, because in the cluster B stuff, that's the erratic dramatic cluster in people. Attention seeking, behaviors is primary, histrionic. But the narcissistic is that sort of that entitlement, right? And that grandiosity. It's like you want, you're feeling like, I want sympathy. Give me sympathy now because look at what I'm going through right now, right? With this sick child, et cetera. So it's a complex interplay. It's not just strictly sort of we call it fictitious disorder, but there's an underlying personality pathology that drives it. Right?
I've actually experienced, she was not diagnosed with fictitious disorder, but I took care of a patient where we suspected mom was. And it was interesting to see the family dynamic, because here is a patient who is in the bed and who is very close to passing away because of how sick she is, but the family was orbiting the mother. It was like they were orbiting all around her and trying to keep her okay. And here is this, and the patient was awake. The patient was awake and watching all of this stuff go on. And we were just like, to be around her made my skin crawl. And when the patient did eventually pass away, mother blamed it on us. She threatened me. And then the rest of the family came after me and a few other nurses. I'd only taken care of the patient for like 2 hours. But because I was there when she declined, which we were not surprised she did. I just want to put that out there. It was not me. No.
Yeah, they locked onto you. Yeah, they locked onto you.
They locked onto me because I was there when they took her to surgery and everything happened in surgery. And then the rest of the hospital, we had to put a, a no trespass order on her and the rest of the family. And we had guards that would walk us out to the car. A couple of nurses found their cars vandalized.
Oh, wow.
Okay, wow. Well, shall we recap on the killer nurses? So I think we covered. I just want to put that out there. You did not make the killer nurse Ross or Shannon. Thank you. So thank you for this important topic today. Thank you for your time. Any final closing comments about killer nurses today?
Only that we're not diagnosing any of these nurses, either alive or deceased, with any disorder because, well, we didn't formally evaluate them. We're merely speculating about what might be going on with them psychologically based on publicly available information, right? That's my little disclaimer on that.
Well, and I'd also like to say is we're not saying that nurses shouldn't be trusted. I think there's many of us out there who work really hard to take the very best care of our patients, and we'll put ourselves in harm's way to do that on occasion. But that it should be in the best interest of every healthcare person who has the potential to cause somebody harm, not deliberately, but to get a psychological evaluation. I mean, why is that an issue? Why should people who have that much power over life and death not receive that kind of evaluation?
I agree. I think, like you said, in these sensitive positions like this, the ones who are directly involved in, the delivery of medications, anesthesiology, and specific specialty areas, there should be perhaps, some carve out for that, right? And again, that's a regulatory thing and all this, that, trust me, is going to be hard to get implemented ever because there's going to be a lot of pushback from like nursing associations or other medical associations because it's privacy violation and all this other, there people are going to argue it's not necessary and all that stuff. But I think somebody should start the conversation. That's a very good point that pilots, police officers, people in sensitive positions who have the public trust, they all have to be evaluated psychologically and they have to be cleared before they can be in their work. So.
And guess who can clear you psychologically? So Dr. Rutter and I can. We do that. And we know the risks as we discussed here today.
We sure do.
We do. So if you need a psychological evaluation, we do plenty of court-ordered ones, and I even do them for licensed professionals and from pilots to psychologists to whoever, use this resource. Contact us or have a plan in place. And of course, Shannon is amazing. She's a legal nurse consult. She can deep dive into those records using that specific expertise to deep dive into the medication records in these civil lawsuits where there is a wrongful death and certain protocols and things didn't take place. Really looking closely at it. But thank you so much for your time today. It was so insightful. Shannon, I love talking with you. And of course, Craig, thank you so much. Thanks for listening. For episode details and merch, check out killerpsychologistpodcast.com. And for forensic services, you can book online at psychologydr.com. That's psychologydoctor.com.